I have questions for all of you, of course. I thought about it. Christine, you are first. I was always thinking about the myth of compression. You said that an impaired arterial flow is not an obstacle for compression therapy. So do you refrain in consequence from an arterial diagnosis of the patients with venous leg ulcers, because that shouldn't play a role in your concept?
No, I think I should clarify what I mean. Historically, we've been concerned about applying high compression to patients with peripheral arterial occlusive disease. And if we remember that actually this is a nurse-led issue, it's a very important issue to make sure that we can identify whether patients have peripheral arterial disease. So this is very important. So always the priority for assessment is to exclude or at least to identify patients with peripheral arterial disease. But the new evidence coming out is that actually we are too conservative in our approach. Hugo Parch, Giovanni Mosti have done work, and it's in a controlled situation, which is very different if you're treating people at home or in the community settings I work. But they've shown that you can use compression safely down to a level of an APBI of 0.3 without causing a reduction in arterial inflow. So I think we are overcautious. However, it does depend where we're treating patients, because we have a huge issue in the community of people not being good at identifying somebody with arterial disease. So I think that's really, there's science done in a lovely controlled vascular department, and then there's the real world where people are being treated. So I think we still need to be cautious, and we still need to make sure we've identified arterial disease. And
arterial diagnosis still belongs to the protocol in diagnosis of venous leg ulcers. Thank you. Sylvie, you've closed your venous leg ulcers by compression and by active treatment. What do you do against the recurrence of ulcers?
For the recurrence, just like Elena explained, it's to observe compression, but adapt compression after the wound closure. In some cases, I recommend to wear a compression bandage all time, because especially in elderly patients, it's very difficult to move from compression bandage to stocking. It's impossible in some cases to have an adapted stocking in very elderly patients. So sometimes I use the compression bandage till all life for the patient, changing once a week in some patients, for example in lymphedema, and when you have a venous leg ulcer with some recurrence. It's frequent. And in France, it's reimbursed. It's possible, yes, to use it.
Okay, thank you very much. And now I have a very ugly question for Elena. You've done such a magnificent work on your 5 patients. How many patients would you estimate you can't cure? So 10%, 20%, 30%?
Thank you for the question. I'd like to answer that question with something that Christine said, that leg ulcers, what she just said, venous leg ulcers, lots of them that they cure. They are not lesions not to be cured. The thing is, I don't really know how many patients do not heal. The thing is that in our clinics, I'm not an expert. I'm in love with ulcers, with wound healing, and that's why. And we all love in my team. We are just I know when a patient comes, we just know that he'll be healed. So now I can say you that we heal all the patients that come, but because I'm very young, I mean this is and we do whatever is needed. But I don't risk the patients that come to my clinics are not oncological patients, but venous leg ulcers with. Well, I'm not answering the question, but the thing is that I don't want to answer that question because I just want to think that all ulcers can be healed. That's my answer.
Yes, and you should think so. Okay. So the purpose of the question was more or less to point out, and that was what the previous speakers had pointed out before, that venous leg ulcer is a constant challenge to all of us and will remain a constant challenge with different aspects and very, very difficult aspects. And there is a development in our view to venous leg ulcers as well, as Christine pointed out. There's the awareness of the danger of recurrences and our constant need to treat patients even after they have cured, after the actual venous leg ulcer has healed. And of course, we do need the courage and the engagement of many, many colleagues like you, Elena, fighting against these ulcers, and don't accept that they won't heal. Don't accept that, ever. Okay, we come to an end of our session. We have introduced you to the 4 Ds, and after a proper diagnosis, it is very important to keep the constant dialogue with the patient, to understand the patient and his needs. And then we may achieve a dynamic healing, and we can decrease healing time. That's the message from this afternoon. I do thank all of you to be here, and I do thank you all for your attention. Thank you very much, and have a nice evening in Amsterdam.